Thank you. Thank you so much. Kurt, are you around?
Yes.
Oh, good. Okay.
Yeah.
Thank you. All right. Okay. Welcome, everyone. So this is our regular Zoom series. Because I am totally disorganized, I have not got any introductory slides. My gatekeeper, Rahul, has to do an extra night shift. So bear with me. So today, you're being looked after by the Dutch. We've got Kurt de Wall, your chair. Say hello, Kurt. And Enrico, who will be our speaker. So before I lose the plot, because I'm letting everyone into the room, I should pass you on over to Kurt. Just a word, we have started recording. Enrico's happy to share it on social media. And if I do get my act together, I'll put the links to social media and to our website onto the chat room. So if you have any questions, type it onto the chat room, and Kurt and Enrico can field them at the end of the talk. So I shall just shut up now and pass you over to Kurt and Enrico. Thank you.
Well, thanks, Julie. Thanks again for just keeping this series running and keeping people always very interesting speakers to telling their stories from now literally all over the world. But today we have the third Dutch speaker who talks his story. And his story, Enrico and I were trained at the same time as a neonatologist, but he was in Leiden, which is a much smaller town than Amsterdam. But what I remember, Enrico, and you can correct me if I'm wrong, back in the days, I thought Leiden was the only referral center for twin-to-twin and laser. I think now you have two, but maybe you tell a bit more about it. So they have built up this, decades of experience in twins, monochorionic twins, and how to manage them, of course, antenatally, but I think Enrico's going to tell most of us about what's going to happen postnatally with them and what sort of the key points and where we should pay attention to. So Enrico, thanks so much for talking today, and the floor is yours.
Thank you, Kurt. Let me see if I do it well. Are my slides now visible?
Yeah, it's all good.
Yes. Okay. So good afternoon or good evening, everyone. Yes, I am a neonatologist, as Kurt said, but I'm very much interested in what happens to babies inside the womb. Especially with these twins, you need to understand what happens inside the womb if you want to understand what happens then after they're born. And I will tell you this today more about these monochorionic twins, a special type of twins who share their placenta. Oh, let me see what that's there. Okay, so why is it important to talk about twins? If you come to think about it, twins only make up 2% of all pregnancies, so it's not much. But at the end of the day, if you look at the NICU, general NICU all over the world, well, 1 in 5 of the babies admitted in a NICU is a twin. And this, of course, has to do with the fact that twins are more often born preterm and more often born with a low birth weight. If you then look further and you look at babies who are extreme preterms, then it's even more. It's 35%, 1 in 3 who are twins. And actually, at the moment, we have a NICU with, at the moment, 19 beds because of shortage of nurses, unfortunately. But of these 19 babies admitted today at our NICU, 10 of them are twins, which is more than average, but still it shows that this is a NICU, an intensive care issue, and you need to know more about twins if you want to treat these babies well. Twins are not two singletons. They have special diseases that you need to be aware of as a neonatologist. First thing you need to know is that there are 2 types of twins, and this is for parents very important, for doctors not that much, for researchers yes, but for doctors not as important as for parents. parents always want to know whether your twins are dizygotic, meaning that they are genetically different, or monozygotic, identical. Dizygotic twins occur when two sperm cells fecundate two different eggs, and then you get two different babies with their own genetic patterns. And actually, this is my twin brother, Marco, and me. I'm the one on the, for you, the right with the big ears. And on the right side, you have the monozygotic twins, which are rarer, and they occur when one sperm fecundates one egg, and then it splits. There is a time where the egg who is fertilized splits in two identical twins, and this cloning process is typical of humans. We often think that animals also have identical twins, but actually that's not the case. It's very rare in animals. It's typical things that occur in humans. Again, monozygotic and dizygotic is not medically very important, but it is for parents important. Now, dizygotic twins, per definition, have a dichorionic placenta. And now you need to remember and know what these terms all means. Dichorionic means two placenta. As you can see in this picture, each baby has its own placenta. And a dichorionic placenta, so two placenta, always have two amniotic sacs. So diamniotic. You cannot have a dichorionic monoamniotic. Dichorionic means you also have, each baby has its own sac, amniotic sac. In monozygotic twin, which is more or less 1/4 of all twins, then it depends in terms of what kind of placenta they have. It depends on when the splitting of the fertilized eggs occurs. If the splitting occurs a few days after fecundation, then these babies will also have a dichorionic diamniotic placenta. So meaning that each baby will have its own placenta. So at birth or during pregnancies, these monozygotic twins actually look exactly the same in terms of placenta as the dizygotic twins. So you cannot tell parents at birth, if they have a dichorionic twin, that they are dizygotic. They could very well be monozygotic. But in most cases, the splitting occurs between day 4 and day 8. That's in 2/3 of the monozygotic twins. And these twins have a special type of placenta, which we call monochorionic, meaning that it's a shared placenta. And these placentas are very special, and I will show you why in a second. In most cases, these monochorionic placenta are diamniotic, meaning that both babies, just like in the dichorionic, have their own amniotic sac. You can see here the intertwin membrane. So one placenta and two sac, we call this monochorionic diamniotic. If the splitting occurs even later, so that's around day 9 to 12, then there will be monochorionic monoamniotic, meaning that they don't only have a shared placenta, but they also share the amniotic sac. And in this case, the typical thing of these monochorionic monoamniotic twins is that they always have a knot in their umbilical cord. In all cases, in the spontaneous monoamniotic, they all have a umbilical cord knot, which can complicate their course. That's why you cannot deliver these babies vaginally, otherwise the knot will tighten and they will die. And it's important to deliver them not too late, around 32 to 34 weeks. And this is how a knot looks like in a monochorionic placenta. They can be knots of all kinds, very complicated, or sometimes they are very tightened and leading to fetal demise. If the splitting occurs even later than 12 days, then you have what we call Siamese twins. And the Siamese twins, this is these twins are called Chang and Eng. They were from the last century, and we call them Siamese twins because of them. They were born in Thailand, Siam, and they were connected through the liver, and they became very famous because a American impresario brought them to America to tour with them and show them as part of probably some kind of act, and they became famous because of that. And that's why we call conjoined twins also Siamese twins. And the funny thing is, is that they married two sisters, not twins, but two sisters, and they had together, joined, they had 21 children. You can just use your fantasy to imagine how that all happened. The important thing is that because they were connected, and one of them was an alcoholic and was like to go gambling, he drank a lot and gambled a lot, and the other one, who was not, was more the introvert type, had to go along, and he got waken up in the morning every time with a headache, and at the end, one died because of too much alcohol, and the other one died immediately after. So that's the tragic part of this talk. But that's a very rare Siamese conjoined twins. Let's talk about the important things in terms of things that occur more often. For doctors, it's not important to know whether it's a dizygotic or monozygotic. What you need to know as a perinatologist, if these twins are dichorionic and monochorionic. I often hear at the handovers in the morning or in the evenings that there is a twin delivering. And I sometimes ask, what kind of twin is it? And they don't always know what kind of twin. That's something that we should know. You have to know whether it's a dichorionic or a monochorionic. And the gynecologists know that. They should know that. And it's easy to do because with the ultrasound prenatally, you can look at the intertwin membrane. In dichorionic twins, the most common type of twins, you have what you call the lambda sign. The intertwin membrane is thick, and when you look with the ultrasound, it has some kind of a lambda sign. In contrast, in monochorionic twins, the intertwin membrane is very thin, and then you have what we call the T sign. And this is something that can be seen easily in the first trimester and should be recorded. And if you know about that and you ask the gynecologist before delivery, then they will tell you, oh, it's a dichorionic or a monochorionic. And why is it important? Well, because the placenta in dichorionic and monochorionic is completely different. This is an example of a dichorionic placenta which is fused, which happens in 50% of dichorionics. Although there are two placenta, because of the lack of space in a womb, they are often fused with each other. And in this case, it's a fused placenta. But as you can see, the intertwin membrane, which we cut off, is still there, and there are no vascular anastomoses connecting the two placenta shares. And this is always the case in a monochorionic twin placenta. They all have anastomosis. So these placentas are, of course, not born like this. We inject them with colored dye routinely. And I will show you what you need to know about that, but this is a typical monochorionic placenta, which you can see there are connections between the vascular injected vessels in both directions. How do we do that, this injection, in which it's actually very easy to do? You just use the catheters that we use in the NICU for injecting, for cannulating the umbilical cords. And then you use colored dye that we actually have from our children from the kindergarten. And when you inject that, it's a bit of you need to get used in the beginning, but then you can see it opens a new world. So I would strongly advise, if you're interested in monochorionic twins, to routinely inject all monochorionic placentas that are born at your hospital. And when you do that, you then can count and identify the type of a vascular anastomosis, and this will tell you why those twins will have or will not have certain disorders at birth. And there are different types of anastomosis, which I will show you in a real placenta. These anastomosis can be between arteries and veins, or between veins and arteries. And this is an example of such a monochorionic placenta. We always have put on the left side the first twin, and on the right side the second twin. This twin has a velamentous or marginal cord insertion, this one a paracentral cord insertion. We always inject the arteries with darker colors. That's because in real life, in the fetuses have a low oxygen content in the arteries and high oxygen in the veins. So the veins always looks brighter if you look in a fetoscopy setting. And then we look at what we call the vascular equator. That's more or less where the vessels connect with each other. And we then count one by one the anastomoses. You can see that this is a yellow vessel. So this is a vein, and it's connected to a vein coming from the other side. So we call this a veno-venous anastomosis. This is called a veno-arterial anastomosis because it's a vein from twin 1, that's the pink vein here, connected to an artery of twin 2, the green one. Artery means that the blood is coming from the baby, from this fetus which is now born, and it pumps blood into this, what we call the cotyledon, a part of the placenta, and it's drained by this vein. And an artery to vein anastomosis, or an AV anastomosis, which is then here, is going the other way around. This is the blood in the artery of twin 1. In the blue artery is connected to the yellow vein from twin 2, and it so drains blood from this cotyledon to twin 2. And you also have an artery to artery anastomosis. This is this green anastomosis here in the middle. This is another example of a monochorionic placenta. They all look different. I've been injecting placenta now for 20 years, and every time I'm surprised to see that it's a completely new placenta. So they're never the same. But there are a lot of important things that can tell you whether or not it can have led to complications. Again, this is showing the vascular equator. This is an artery to artery anastomosis, or the green connection. And then you have all kinds of other anastomoses, artery to vein and vein to artery. The important thing to know is that the different type and sizes of the anastomosis will determine whether or not these monochorionic twins will get TTTS, TAPS, or other kinds of complications. So maybe it's too complicated for now, but remember that the type of anastomosis makes the difference. Now, of these monochorionic twins, because those are the ones who have the most problem. In dichorionic twins, they never have anastomosis, so they won't have all these complications. Most of the monochorionic twins, so 3/4 of them almost, don't have any complications. We call that normal monochorionic twins. They are in balance. But in 1/4 of them, all kinds of complications can occur, ranging from the classic chronic TTTS, which is around 10 to 15%, to selective IUGR, or selective fetal growth restriction, to TAPS, twin anemia polycythemia sequence, and then you have all kinds of other rare diseases, monoamniotic twins. Those are the one in one sac with the umbilical cord knot. TRAP, twin reversed arterial perfusion. I won't talk about this because of lack of time. And you can have also acute peripartum TTTS. I will shortly talk about this in a short while. So as I told you before, all monochorionic twins have vascular anastomosis. So this is not strange. This is completely normal. And in 3/4 of them, they are imbalanced, meaning that each twin gives blood to the other and back again, so that they have at the end of the day the same amount of blood and the same amount of amniotic fluid. They don't have any problem. But in 1/4 of the cases, feto-feto transfusion can occur, meaning that one baby gives more blood than to the other than it receives back, and then you have a disbalance. And this disbalance can lead to a volume shift, meaning that one baby receives more blood volume. And if that occurs, you can get twin-twin transfusion syndrome. And twin-twin transfusion syndrome is also called TOPS, twin oligo polyhydramnion sequence, because due to the volume shift, one baby becomes hypovolemic because it loses blood and then starts peeing less, has a oligohydramnion, while the other one who receives more blood will become hypervolemic and gets a polyhydramnion. And this is the TTTS, this is the most dangerous complications from all the other complications that you can have in monochorionic twins, and this needs to be treated well and quickly. In another situation, you can have not a volume shift, but a shift of erythrocytes, and this is what we call twin anemia polycythemia sequence. In these babies, which I will talk later, you don't have a large volume shift, so these babies will not have a hypo and hypervolemic condition, will not have an oligopolyhydramnion situation, so they both have the same amount of amniotic fluid, but they have a difference in hemoglobin. But I will start by talking about the TTTS, because that's the most dangerous and the most severe complication in monochorionic twins. What is TTS? As I told you before, the donor has oligohydramnios and the recipient has a polyhydramnios. And this is due to an unbalanced intertwin transfusion through large anastomosis on the placenta. It occurs more or less in 10%, 10 to 15% of monochorionic twins. So it's not rare. And the diagnosis is made by the gynecologist. In the past, we thought as neonatologists that we could diagnose at birth whether it was TTS or not. That's not possible. You can only diagnose this before birth with an ultrasound, and then the ultrasound shows you the oligopolyhydramnion, so a difference in amniotic fluid. The gynecologist also looks at the bladders. The bladder of the donor can be empty, and if that's the case, that shows that it's even worse than in case where there is still bladder filling. And they always also look at the blood flows, and why they do that is that because they have a staging system called the Quintero staging system, and they use these measurements to stage the TTTS. And this is an example. So you can see here on the ultrasound the oligohydramnios, and here the donor, the polyhydramnios in the recipient, and here the oligohydramnion in the donor twin. On this image, you can see the intertwin membrane completely stuck against the body of the donor. That's why we call the donor the stuck twin. And you can imagine that if this goes on for days, then it's very difficult for such a donor to survive. Now, what is the treatment for TTTS? You need to treat these babies in the womb. If you don't do that, most of them will die. They will die because it occurs usually around 20 weeks of gestation. And if the polyhydramnios is not treated, then the babies will be delivered because the mother cannot hold them anymore. So we need to treat these babies, and the best treatment has been shown now already 20 years ago is laser treatment. And this laser treatment, after it's been done, survival is still not perfect because 1/4 of them will still die, most of them in the womb, but it is better than not doing anything, but we're not there yet in terms of optimal treatment. And how does that look like? This is a drawing of such a laser operation. It's a fetoscope going inside the womb, identifying all the vascular anastomoses on the vascular equator, and then burning them with the laser one by one to make sure that the babies are not connected anymore. And this is how it looks out like in real life. There is an ultrasound person showing where the placenta is and where the babies are, then one or two fetoscopic surgeon looking at the screen, and you can see here the screen on the left side to see where the anastomoses are, and burning one by one the vascular connection. And this is how a placenta then looks like after laser. What we nowadays do is, after we've burned one by one the vascular connection, we draw a line between the dots. So we line all from one side to the other of the placenta. We call this the Solomon procedure, and this way the two are completely separated. Now, before we had this treatment, the only thing we could do was amnio drainage, so draining the sac with the polyhydramnion, or amnioreduction. The problem with this treatment, this is the only treatment you can do if you don't have the possibility of doing laser surgery, is that it's not a causal treatment, it's a symptomatic treatment. So it will help just for a few days, but then within a few days, the polyhydramnions will be back and the mother will be probably in labor because of that. And most of these babies, after a couple of amnioreductions, will deliver. So the average delivery, gestational age of delivery in cases treated with amnioreduction is 28 to 29 weeks. And that's actually the biggest problem of TTS, is that most of them are born preterm and they suffer from prematurity. In laser treated cases, the average gestational age at birth is 1 month later, so 32 to 33 weeks, meaning that still most of them are born very preterms, but it's 1 month older than the amnioreduction. So we know as neonatologists how important that extra month can be. So the biggest problems in terms of morbidity in TTS that you should be aware is primarily related to prematurity. And this you know how to treat. So I don't need to tell you anything about that, just that realize when you counsel parents and patients who have TTS, they need to know, of course, that they will have complications due to prematurity. But in addition to that, they have morbidity that is specifically connected and related to TTS. And in donor twins, they are often growth restricted because they have a smaller placenta share than the recipient twins. And in cases that have not been treated with laser surgery, they also often have renal failure because of the chronic hypovolemic situation. In the recipient twin, whether they have been treated with laser or not, we often see cardiac problem. And that is very interesting and also very important for neonatologists to know about, because in 4 to 11% of cases, even treated with laser, the recipient will develop what we call the right ventricular outflow tract obstructions. That's an obstruction of the pulmonary, at the level of the pulmonary valve, more or less. And these babies, if you don't know about that, that this is going on, at birth, this baby look cyanotic. But because they are born preterm, as in most cases, the majority of neonatologists will primarily think, oh, the cyanosis is probably due to the fact that they are preterm, so they have surfactant deficiency, they have a respiratory problem, which most of them have, and they will focus on treating the lung. But it has, that's the wrong treatment for these babies, because what they need is a balloon valvotomy. So it's important to know about this complication before birth. And if it's after birth, if you don't know about this complication, well, remember that this is something that is not rare in TTS, and ask the cardiologist to look if there is a right ventricular outflow tract obstruction because it needs a completely different management. In 5% of recipients, you have pulmonary hypertension. Also important to know because these babies are also cyanotic at birth and they need nitric oxide as a treatment. Then there is a condition called TAPS that can occur in TTTS. I will talk to you about this in 5 minutes. And another complication that is rare but still quite terrible to see, it's called amniotic band syndrome. Because of the operation, amniotic bands can float around in the amniotic fluid and they can constrict limbs, extremities, causing amputation of toes, fingers, sometimes even a leg or an arm. So it's important to know about these two. Now, the most important outcome for parents in who had TTTS is to know how these babies will do on the long term. And what we know is that these babies are at risk of impairment on the long term, especially if they had been treated with amnioreduction. In babies treated with amnioreduction, 1 in 5 will have severe long-term impairment. This is goes down to 10% in treated with laser. It's still a lot, but it's 50% less, of course, than in those treated with amnioreduction. The good news is that what we've seen in our center is that there is a learning curve in this operation. And at the beginning, we had a lot of complications when we started doing the laser surgery in 2000. Well, we saw very often cerebral injury and also in the survivors, very often impairment. But now it's going down. And in the last cohort that we looked at of the survivors with TTTS, well, the risk of impairment was down to 3%. We now looked at these babies when they are older and it's going up again, just recently published. So I think it's fair to say that around 5 to 10% of the survivors, after you've had a lot of experience with doing this laser surgery, will have impairment, meaning that the majority will not. So that's the good news about this. That's what I wanted to tell you about twin-twin transfusion syndrome. And now I will move over to the twin anemia polycythemia sequence. This is a new disease. It was discovered now 16 years ago. We found out about this disease and we're trying now to describe it more and more, but it's still complicated for most people. So please bear attention. So as I told you before, we described it in 2006, but it's a different disease than the TTTS. In this case, in TAPS, the donor doesn't have hypovolemia, but is anemic, and the recipient is polycythemic. And it's due to vascular anastomosis, which are very small on the placenta, and there are very few. In contrast to TTTS, the anastomoses were large and many. In TAPS, they are very tiny and very few, and you can almost not see them with your naked eye. Important to note that there are 2 types of TAPS. You can have spontaneous TAP occurring spontaneously in a monochorionic twin, but you can also have TAPS after laser. And this occurs when you treated the TTTS with laser, but you missed an anastomosis. And if you missed a small anastomosis, you can get what we call post-laser TAPS. And this is how TAPS look at birth, TAPS twins. One is white, anemic, and the other one is red, potato, tomato twins, they call that in America. And TAPS occurs in around 5% of monochorionic twins. And 5% doesn't sound like a lot, but if you then count in the world how many monochorionic twins are born, because that is the same all over the world, wherever, whichever country, then you will see that around 60 to 90 TAPS twin pairs are born a day in the world. And I know for sure that the vast majority of these TAPS twin pairs are wrongly treated, are wrongly diagnosed, and that's just because most people don't know about this disease and they call it in a different way. And the reason why it's often misdiagnosed is that the screening is not yet performed routinely in most countries. And the only way to detect TAPS is by screening with Dopplers, because these babies, in contrast to the monochorionic twins with TTTS, these babies with TAPS have similar amount of amniotic fluid. So you will not notice any difference on the amniotic fluid disbalance. But what they do have is a difference in Doppler blood flow. When you look with the Doppler blood flow at the brain of these babies, you will see that the donor has a high velocity in the arteria cerebri media as a sign of fetal anemia, whereas the recipient has a low blood flow velocity as a sign of hyperviscosity in this cerebri media. There are other signs that you should look at as a gynecologist. One of these signs is the discordance in color of the placenta. And the other sign is the starry sky liver, which is typical in the recipient. But these are things that most gynecologists in the world don't know and don't screen, and that's why most of these TAPS cases are missed and are discovered only at birth. Why do we have these differences in blood flow velocities? Well, because the donor has very thin blood and the blood flows quickly, just like would lemonade, and the recipient has thick blood, and this thick blood flows slowly. And if you then plot the velocities in a graph that all gynecologists have, you will see that in typical TAPS cases, the recipient will have low blood velocities, whereas the donor has velocities going above what we call, this curve is the 1.5 multiples of the median. And as I told you before, the cause of these TAPS is purely due to the typical anastomosis. If you look at this TAPS placenta and you don't look carefully, you will probably see no anastomosis. But if you then look more closely, you will see there, just on the bottom side of this placenta, very, very tiny anastomosis, which is smaller than a millimeter. And you can only see this anastomosis if you inject this carefully with colored dye. And this anastomosis, in the beginning, people would not believe that such a tiny anastomosis would cause any problems, but now we know for sure that it is the cause of the problem. And such anastomosis, we've been able to measure the blood flow across this anastomosis, and it's in the order of 10 milliliters per day. So if you have only one anastomosis, the donor will lose around 10 milliliters per day. Well, for a baby of 500 grams or a kilo, it's still a blood transfusion a day. And it is a chronic condition, so this donor will have time to